start introducing my friend Davide, who is currently a pediatric cardiology consultant at the University Hospital in Bristol, in UK. But Davide and I, like we met in Toronto, in Canada, where he was again a staff pediatric cardiologist. We see kids in 2016, but he is of course, as you can imagine, Italian. So he graduated and also completed his pediatric training at the University of Verona, in Italy, where he also obtained his PhD in multimodal imaging. He then completed his training and work as a pediatric radiologist and cardiologist in Paris at the Hôpital Necker in Paris, in France, and then moved to the Ospedale Pediatrico Bambino Gesù in Rome, and for a brief period in Turin at the Ospedale Regina Margherita. We invited Davide because he's, one of the, big experts on MRI, the use of MRI during the fetal period. And in Toronto, he particularly focused his interest in the impact of congenital heart disease on brain development. As I said, he has huge experience in of the fetal part. So thank you, Davide, and welcome.
Thank you, Alviso, for the very kind invitation, and all you spending some time to listen. What I will try to share with you, to present in the next hour. Studies and experience that I've been involved in when I was at the ECHSA-SICCH in Toronto. Thank you again. I will spend a few minutes to introduce why we got there, then to recall some early experiences, and then for most of the time I will present some illustrative cases coming from the clinical practice and some future perspective. A bit more than 10 years ago, it became evident, the concept that brain dysmaturation, typical of newborns with congenital heart disease, has its origin in the prenatal period. Fetuses with congenital heart disease, in blue, have smaller total brain volume than normal controls in red. White matter injuries, the lesions we typically find we study in congenital heart disease newborns were discovered early in the second trimester in autopsies of fetuses with hypoplastic left heart syndrome who underwent termination of pregnancy. In this sense, the necessity to understand the impact of the congenital heart disease in fetal brain growth and maturation pushed Mike Seed and Chris McGowan to develop MRI technology in Toronto, capable to study the fetal circulation non-invasively. These technological advances allowed to demonstrate that reduced fetal cerebral oxygen consumption is associated with smaller brain size in fetuses with congenital heart disease. On the other side, as you can see from this large series of more than 1,200 neonates with a prenatal diagnosis of congenital heart disease, high incidence of discordances were found between pre- and postnatal diagnosis. Despite a completely different diagnosis was found only in less than 3% of the cases, partially different with major or minor impact on the neonatal treatment was found respectively in 7.7% and 18.7% of the total cohort. in 7.4% of the total population, the discordances had a negative or positive impact on long-term care strategy. Moreover, amongst the fetopsy available, more than 1 on 5 fetuses had diagnostic discordances with potential impact on a future management. Therefore, aiming to improve the accuracy of the prenatal diagnosis, colleagues of London generated a high-resolution 3D volume acquisition of the fetal heart and validated these sequences for diagnostic purposes. In 10 fetuses out of 85, all with known congenital heart disease, new anatomical features previously undetected were found and described, all of which were confirmed postnatally. So I've been very briefly talk about why we got there. Now, why fetal cardiac MRI is challenging, of course, for fetal movements, fast heart rate, the difficulty to have a synchronized ECG synchronized acquisition because of the small structure, because of the maternal respiration. In order to acquire gated images of the fetal heart, different approaches have been developed. The technique I use in Toronto is called metric optimized gating, MOG, which is a process of retrospective image-based cardiac gating. In this process, try to make it very simple, data are temporarily over-acquired to ensure full sampling at the lowest anticipated heart rate, 110, for example. And then these images are from a computer reconstructed through a range of candidate heart rate until a plausible result is obtained corresponding to the real heart rate. And this is usually performed as an offline post-processing step. As already anticipated, the most exciting achievement of MOG in Toronto has been the possibility to detail blood flow.
Non è la chirurgia pediatrica questa è la pediatria, sono di là.
By using phase contrast sequences. More recently, MOG have been combined with other different techniques I will not go into, capable to reduce the timing required to make fetal images, and therefore to reduce artifacts from fetal motion and from maternal breathing. This technology allow clinician to admire beautiful clips like this standard for chambers view and this short axis view. Instead of this kind of images. Although also oximetry is possible with MRI technology. As you can see, the blood into the umbilical vein has higher signal, is bright, has higher oxygen saturation. The umbilical arteries, which have lower oxygen saturation, are darker, have darker tissue signal. And this is the same in the heart. The most oxygenated, the aorta in the normal heart, is brighter. Then we have the MPA, and then the darkest is the blood into the SVC in this 3-vessel standard view. Because of the different magnetic properties of the oxygenated and deoxygenated hemoglobin, the tissue of blood has almost a linear relationship with its oxygen saturation. It is possible to have quantitative numbers from this relationship. If we have a tissue of 80 milliseconds in the descending aorta, we will have oxygen saturation of 50%, for example. The other variable that has an important influence on T2 is the hemoglobin concentration. for the same saturation, there is a shortening of T2 when the hematocrit is higher, as you can see. Therefore, in order to make accurate oximetry measurement, it is also necessary to know the hematocrit. Again, a strong correlation between hematocrit and T1 signal of the blood has been proved. Higher the hematocrit, and shorter is the T1. But just as T2 is primarily influenced by the saturation and secondary by the hematocrit, T1 of the blood is determined mainly by the hematocrit, but also by oxygen saturation. And with mathematical process, it is possible, combining T1 and T2, to derive both oxygen saturation and hematocrit. This is, very briefly, the principle. And this approach has been proved accurate when compared with gold standard conventional blood gas analysis, both in vitro and in vivo. Other centers have developed other solutions. This solution has been developed in Germany, and there is an MRI-compatible Doppler ultrasound gating, which must be positioned over the fetal heart, and this can guide the MRI synchronization. Of course, if the fetus is moving, also the probe, the ultrasound detector should be moved to follow and to keep him connected to the heart in the proper way. So I've been briefly talking about what we got there, and I've given some basic principle about most diffuse technique. Now, in more detail, what fetal cardiovascular MRI can do in clinical practice. Well, fetal cardiovascular MRI can help to recognize cardiac and extracardiac structure. It can evaluate the impact of the congenital heart disease on the fetal body, on the lungs, on the brain, and on the placenta. It can also be useful to evaluate the impact of invasive and pharmacological intervention. This mom was referred because of a large VSD in the fetus. There was also suspicion of right ventricle diverticulum, a very unusual case. Here you can see fetal CMR confirm the echocardiographic suspicion in four-chamber view. Here, in short axis view, we can see the VSD, the ventricular septal defect, and again, we can see this long digitiform diverticulum. After birth, this child was found with cutis marmorata, and she was discovered with a CRIT1 mutation, which probably is explaining this kind of phenotype. This is a postnatal CT, and which was done at birth before surgery. And what we can see from this volume rendering images that there is the pulmonary arteries are disconnected. There is a left pulmonary artery from a left duct originating from the brachiocephalic artery, and then there is under the concavity of the aorta the second duct feeding the right pulmonary artery. There was this right arch, and also there was this mild compression of the trachea, as you can see. This was postnatally. Let's see what was prenatally. These are cine images reconstructed, and again from above we can see the SVC, the right aortic arch, and the left duct here, and then we can see that there is a single ventricle with undetermined morphology, absent right atrioventricular valve connection. There is a large left atrioventricular valve between the left atrium and the single ventricle. The aorta is arising here from a long muscular infundibulum. Here you can see there the long infundibulum. The branch pulmonary artery were not confluent. If we follow the duct, we can see they are disconnected, and we can recognize all the anatomy described previously. These images can be reconstructed in a different way. This is the same patient. We can see the single ventricle, the absent AV valve connection, the infundibulum. Try to stop the movie to show you. Yeah, this is the left pulmonary artery, which is as described from the CT, is arising from the left duct. This is the left duct I showed you before. So this is the right duct here, coming from the concavity of the aorta, and the pulmonary veins were normal, as you can see. They are all draining in the left atrium. And interestingly, these images, these findings were all already described from the fetal echocardiography. What was not described, as I said, was this mild compression of the trachea. We can see in this sagittal view, and we can also see again in this axial view, mild compression of the trachea. So in this case, we had a very good detail both of intracardiac and extracardiac structure of a very difficult prenatal diagnosis. Here, these are just sagittal images, and you can see this right pulmonary artery dilatation. The tetralogy of Fallot with absent pulmonary valve is very easy to be recognized by echocardiography in fetal life. What can be added by the MRI is the diagnosis of atelectasis and liquid trapping, which can orient the perinatal management of the newborn. This is a very old case, but I like because the images are very complete and very detailed. In this axial diaphragmatic view, you can see 3 vessels, descending aorta, IVC, a further vessel here. This vessel in sagittal is going quite high. It is not the IVC. It's coming from the liver, and it's very posterior. I'm sure you have already understood what is the diagnosis. Again, you can see that the pulmonary veins are not draining into the left atrium, and this is a bit more difficult to see if you don't have quality in the screen, but you can recognize the typical aspect of total anomalous pulmonary venous return in diaphragmatic version. You can recognize maybe the 3 inverted reverse, 3 typical of the infradiaphragmatic total anomalous pulmonary venous return. For each of these vessels, the flow can be calculated. The important in 2D flow measurement is to be perpendicular, so the prescription needs to be very accurate. Otherwise the calculation can be very challenging. But it is interesting to see that after reconstruction, the shape also of the curve, of the flow curve, are very reliable. Going back, just to underline, this is the aorta, typical short axis view, the MPA, the arterial duct there, the superior vena cava in this 3-vessel view. You can see the flow, and this is the umbilical vein in the middle. My connection is unstable, I hope not. Anyway, we can also measure the flow into the IVC or into the descending aorta and into the descending vein. As I said, with T1 mapping in the umbilical vein and the 2 mapping of the umbilical vein, we have one possible combination, giving in this case 81% of saturation in umbilical vein and 45% of hematocrit. And applying the Fick principle, we might have fetal oxygen delivery and consumption, but also not only fetal, but also cerebral oxygen delivery and consumption. And this can be correlated with the function of the heart and with the future outcome. So we have seen some cases for anatomical and functional assessment, and let's see some other in which fetal MRI has been useful to monitor some fetal intervention. This mom was referred for eye drops. Eye drops can be easily segmented and calculated. And you can clearly recognize this diagnosis, right? Which is an Epstein anomaly with severe regurgitation of the tricuspid valve and dilatation, etc. In severe form of Epstein anomaly and the tricuspid valve dysplasia, the failing right ventricle is not capable to open the pulmonary valve and to generate a forward flow through the main pulmonary artery and the arterial duct. And so the duct flow comes backward from the aorta. If there is pulmonary regurgitation, then a loop of blood flow occurs. And this is a life-threatening hemodynamic condition, having the potential to provoke low perfusion of the brain as the pulmonary regurgitation steals output from the aorta and from the epiaortic vessel through the arterial duct. In one of these patients, we were able to perform a fetal cardiac MRI before to start an off-label therapy with indomethacin, and 1 week after. The goal was to reduce the circular shunt by provoking a pharmacological intrauterine closure of the arterial duct. And the hemodynamic and oximetry assessment confirmed the dramatic reduction of the circular shunt flow and the overall increase of the cerebral blood flow and the cerebral oxygen delivery and consumption. This mom was referred because of early diagnosis of sclerosis tuberosa in the fetus. At 31 weeks of gestational age, the MRI showed a unique mass emerging from the interventricular septum and the lateral wall of the left ventricle in presence of pericardial effusion. Only the left ventricle inlet is visible in this axial view. But coronal CNA imaging easily demonstrated the mass menacing the patency of the left ventricle outflow tract and provoking left ventricle dysfunction. Volume segmentation can be also useful to measure the total volume of the mass, as we normally do for the heart, the ventricles. And fetal brain MRI show multiple cortical and subcortical tubers. The most conspicuous was right frontal, measuring approximately 6 millimeter, but there are some others, as you can probably see. The kidney were instead normal. This mom underwent off-label treatment with sirolimus, and control fetal MRI was performed 1 month later, demonstrating a dramatic reduction of the mass from 40 to 17 millimeters of mercury. And after birth, surgery was not necessary for this newborn. In transposition of the great arteries, the higher T2 mapping in left ventricle compared to the right proves that the shunt through the foramen ovale is florid, right? In one fetus with TGA and restrictive foramen ovale, data show that the oxygen saturation were higher in the right ventricle than in the left ventricle, with very little flow across the foramen ovale. Balloon atrioseptostomy was performed in utero, and following this intervention, the CMR confirmed a healthy shunt across the foramen ovale and a much improved saturation in the left ventricle. This mom was referred at 26 weeks of gestational age because of hypoplastic left heart syndrome with mitral atresia. You can see that there was a restrictive atrial communication. Fetal MRI showed the typical nutmeg pattern, which is defined as a heterogeneous signal with a tubular structure radiating peripherally from the ila, as we can see in these axial images, confirmed in these coronal images, also showing a mild pleural effusion. All these signs are considered pathognomonic diagnostic for lymphangiectasia. Again, this is the same image I have already shown you. This fetus underwent percutaneous interatrial stenting. 2 weeks after the procedure, the stent was still in place and patent, although protruding into the left atrium. And so 14 weeks later, just before birth, was still patent. At birth, a mild interatrial gradient appeared, but not very so high. But at birth, no radiological traces of lymphangiectasia and no pleural effusion either. When the patient underwent to bilateral pulmonary bending as a bridge to delayed Norwood operation, the biopsy of the lung did not show any sign of pulmonary lymphangiectasia. What might be the explanation? Maybe the MRI was wrong. We will never know, but why not believe that early interatrial stenting might have been effective to reverse the pulmonary lymphangiectasia? And this is, of course, the explanation I prefer. Unfortunately, however, this patient then developed early pulmonary vein stenosis, suggesting that maybe the natural history of the disease has not really changed. As anticipated, the group has made the fetal cardiac MRI as a routine clinical tool is the London's Evelina and King's College of London. This fetal scan, this is a fetal scan of a fetus recently, 2 days ago, born in our center. And in this fetal scan, a right diaphragmatic hernia was discovered, revealing the liver protruding into the chest. There was also a big azygos, right azygos vein. There was some suspicion, hypoplast, a bit of slender hypoplast aortic arch, And of course, this was the main concern, the left pulmonary artery sling across, surrounding the trachea. As I said, the London's team offer this kind of 3D reconstruction, which are very nice. You can see the descending aorta, the LPA, the pulmonary sling here, this big azygos draining into the left superior vena cava. Again, the trachea and the slender aortic arch, as you can see, without as often occurs in this patient, but with no true coarctation. Yeah, these reconstructions are extremely beautiful, but this is the postnatal CT. And we need to remember that these are manually done and therefore limited by the quality of the native acquisition. Postnatal CT, for example, reveal additional details like this very curious normal hypoplastic LPA. So there was the sling of the main left pulmonary artery, but there is also a further left, smaller hypoplastic left pulmonary artery, and probably there is these images raise the suspicion of chicken trachea rings, which can very much complicate the surgery. Unfortunately, bronchoscopy has not been done yet, so I will not tell you if there is a ring sling complex or not. What is fantastic, in my opinion, is the multidisciplinary collaboration in London Evelina. One MRI has 3 different very detailed reports, one from the heart, one of the body, and one from the heart, all signed by a specialist for a total of 9 pages. And as you can see, as in Toronto, this require high team working. These were just for the heart, but there are also other eminent specialists in fetal imaging signing every report, and so providing an incredible amount of data for both research and for clinical support. What are the limits of the technique? Well, there are still many limits. These are fetus-related or mom-related. Fetus-related are gross movements early in the 3rd trimester, polybramnios, timing, or mom-related obesity, claustrophobia, back pain, or piercing. Sometimes I found myself remove piercing for a mom with dozen of piercing anyway. Or mom too obese to fit in the scan. So there are some, or panic attack. Mom in pregnancy are somehow more emotionally distressed, of course, and so it's not rare, this kind of daily life situation. So what are the perspectives in research? I will just cite some of them. Recently, it became possible to acquire phase contrast images in multiple directions, and this data can be used to generate vector flow maps and provide information about complex intracardiac flow pattern. This is, for example, visualizing the streaming of oxygen in the blood. This is a normal late gestation human fetus, and we can see in red how the blood returning from the placenta is streamed across the foramen ovale into the left heart, while the blood returning from the lower body in blue passes via the right heart and the ductus arteriosus into the descending aorta. So for the first time, dynamic vector and flows has been coupled with oxygen content of the streaming. Of course, this was not one of our patients, and the wonderful thing about working with animals is that invasive blood pressure transducer and general anesthesia allow to have accurate synchronization, and so it is possible to achieve very high quality imaging. And so it is possible to segment the ventricle volumes as we normally do after birth in children and in adults, to calculate volumes and ejection fractions. When a myocardial infarction is provoked in fetal shape by tying off a branch of the left anterior descending coronary artery, we can study the regenerative properties of the fetal myocardium. For example, this short axis cine images clearly show regional wall motion abnormality in the apical left ventricle free wall induced by ligation of a branch of the LAD. And with late enhancement, the myocardial infarct can be confirmed and quantified by using commercial available feature tracking. All these technological advances obviously represent new promising instruments for prenatal invasive and pharmacological fetal intervention. The use of anesthesia and intracardiac catheter allow for very long acquisition of a very high quality image. Sorry, I was trying to run again. Anyway, and this allowed the application of a true 4D volumetric fetal flow imaging. Can probably try to have, you can see also the heart and the vessel are moving. So not only the vector, but also the structure of the heart. And this is the proper 4D flow normally used in adults. In conclusion, in my opinion, we are in transition from a screening approach to a precision medicine approach with new goals. To modify the natural history of the congenital heart disease through fetal intervention, to provide more accurate counseling covering not only mortality and surgery, but also neurodevelopmental and quality of life, and with new goal of identify modifiable risk factor for neurodevelopment impaired outcome. These goals, in my opinion, require more accurate prenatal diagnosis and risk stratification for each single congenital heart disease, longitudinal follow-up, and of course, multi-center registries. Fetal MRI, my experience, is driving discovery in fetal physiology and development, and is becoming useful clinical tool, complementary to ultrasound, and able to provide all-inclusive assessment of anatomy and function of heart, brain, lungs. New technological advances are rapidly improving imaging quality, and the impression is that we are just at the beginning. Of course, this is a team working process. I was one of the with Mike involved in the main scanning. It's a challenging but fascinating domain, and thank you very much for giving me this opportunity to share this experience. If you have a question, I'm happy to chat with you.
Thank you so much, David. This was a wonderful lecture. Also, like very innovative thing. I don't know if there are questions from our audience or like those that are connected. I can start with one question that actually came from Dr. Veronese, but I also think it's very important. So it looks like there are many spectrum of disease that can be investigated with the fetal MRI, but we are particularly interested in knowing which of those that can be explored with fetal MRI, in your opinion, are particularly indicated to be worth of this examination. Like, do you have a specific protocol? Like when you find like these particular cases, then with the ultrasound, then you go for a further and more sophisticated analysis with the fetal MRI, or you're just still in the research phase where you're kind of like exploring.
Yes. Well, I can share both the experience I'm through. In Toronto, the only true clinical indication was mainly the research of the lymphangiectasia in hypoplast with a restrictive interatrial septum, and this was not heart, it was the lung. If we want to be more strict, but of course, when you have a facility, when you have a tool. The indication are wider, because all fetal cardiologists are happy to have a support in complex diagnosis, and that's why in London is used every time the fetal cardiologist with ultrasound want to be reassured or wanted to explore complex cases with syndromes or many pathologies, as we've seen many malformation, hernia diaphragmatic. For example, I was fascinated by another cases that I've not shared with you because maybe too much, but a total anomalous pulmonary venous return was a scan, and also he had lymphangiectasia, and for example, so because it was already obstructed. I think the top indication is, of course, syndromic or multimalformated, because more than one organ can be assessed. This requires multidisciplinary approach, and then it depends clinical from research practice. I think that in this domain we are still complementary. Research is still complementary to clinic, and clinic is complementary to research, because all these are completely new and needs to be validated, and experience is growing. So utilities, prognostic factor will appear as soon this method will be used diffusely.
Thank you. Couple of technical questions. So, do you need to sedate the mom and or fetus for fetal movement? Like, did it happen to you that you had to do sedation for this reason? How did it?
Yes, no. There is so far no known technique or modality to sedate to calm down the fetus, and that's the main difficulties of this technology, because earlier you perform the scan and more the fetus has space to move and more active he is. That's why images are better in the second part of the third trimester, when also the decision to interrupt, for example, are already taken in most of the countries. So there are no facilities, and there are no possibility. Also the mom. Sometimes I had a good result with some kind of mindfulness meditation and pseudo hypnotic approach. I remember one mom I was able to scan her, despite she was almost in a panic attack. But also the mama no is not I think ethically approved and common clinical practice to sedate the mom, to my knowledge. That's never happened to me, you know.
When you scan for the fetal heart, do you need a different protocol, like in case you want to explore the other organs, or let's say if you're looking for the kidneys, the lung, or whatever, from just a technical point of view, like do you need to do something different, or the scans are the same?
Yeah, that's a good question. No, it's a one coil abdominal pelvic coil, which is put over the belly, the tummy, and sometimes the sequences are the same, and so the localizer, for example, can be used. Of course, more the body is normally the same sequences, so you don't spend more time to scan the body. I mean, the chest and the abdomen, for example. If you wanted to do a more detailed scan of the brain, some additional sequences should be added. So also yeah, it's as all the MRI. There is also a list of priorities because so far we cannot scan the mom for more than 40-45 minutes. This is reasonable, accepted, but not very much more. Yeah.
What is
safe? There are no evidence, but it's suggested to there is some limitation in the exposure, and the machine know already is set up to stop and never reach these limits. But the common sense is to limit the time, also because often the mom have back pain, or so it's not very comfortable, the position. So that's another key question.
Yeah. What is the thickness of the slices? Like here we're pushing a lot for 3D reconstruction, kind of like these things, and also just to understand the accuracy, how much, what is the minimum?
Yes. For example, depends a bit on the machine. The protocol, the black blood protocol in London is a submillimetric for the haste sequence they use to create the volume. And in our center, these are not necessary, and so the slice cannot be overlap, for example, so we are 1 millimeter, if I remember properly.
Well,
I can provide the specific.
Yeah, just reporting questions from like others. What is the
very technical question? Yeah.
What is the earliest time that you can do like a proper fetal MRI? Like Dr. Raffo asked if you can do it at 25 week of gestation.
Yes. Again, it depends on the question. If we wanted to scan the heart in just the heart of the fetus, just for diagnostic purpose, yes. In London, they started very early. They started in their papers 24, 26 weeks. But I'm not sure the quality is always good enough, for the reason I explained. That's why in Toronto, when I used to scan after 32 weeks of gestation. But technically it can be done before. It depends. It depends on, because we were doing the flows, we were doing a bit more sophisticated investigation. So it depends on the indication.
And maybe we miss it, but how long is the full scan? Like how long is the the examination? Like,
yeah, it also depends. Also depends very much on the indication. If you wanted to just to look at the lungs in an hypoplast, this can take 15-20 minutes. If you wanted to achieve an assessment, complete assessment with some functional, it means functional, I mean a cine sequences allowing for cine reconstruction or flow reconstruction. This can be much longer, and of course it depends on how much the fetus is stable, because as I said, when you are, the difficulties of the technique is to follow the fetus when he moves, is to understand how the heart has moved, and so to prescribe quickly accordingly to the movement. So less the fetus move, quicker is the exam. I don't know if I have answered the question. But of course, at 38 weeks gestational age, the fetus is trapped, and so you can scan easily, easier in an easier way than 24, when you can swim into the liquid.
The machine you used in Toronto was a 1.5 or a 3 Tesla?
1.5. 1.5, yeah, 1.5, less artifacts. 3 Tesla is better, is probably better for a small vessel for the flow, but we have better result, generally speaking, in terms of anatomy and reduction of artifact with 1.5.
Yeah. I believe Dr. Di Salvo, professor, has question.
Hi, Davide. Thank you very much. Very nice presentation. Just a physical question. Since the volume rate of the CMR is quite slow, is this a limitation when you need to assess, a fetus with 150, 180 beats per minute in terms of functional assessment, or in terms of looking at the AV valves, for instance, or VSD?
In the heart, you mean?
Yeah.
The part is the heart rate is not a problem. I mean, some studies have been done comparing increasing the heart rate, for example, during physical activity in small vessel, to use MOG, this technique of resynchronization, and to see how much reliable it was. And this test has been successful for the flow. Honestly, for the heart itself, I probably show you one of the best image before. I don't know if you were there, but of intracardiac abnormalities. Because if we look at for example, all the papers in London, all the cases in the series, they were all extracardiac structure, extracardiac vessel, because it's more difficult. I mean, the black blood sequence is good for vessels, but not so much for heart itself. So the best we had was that beautiful diverticulum. And we saw the VSD, but I mean, this structure are better seen by echography. So that's why we are very proud of that case. But most of the patients are addressed for extracardiac structures.
Thank you.
My pleasure.
From the online audience. All right. Thank you so much again, Davide. This was very useful, I think, and wonderful. I think we are going to reach out to you, or at least Helena and Paola will reach out to you, when I'm not sure when we're starting but we're ready. So maybe
that's very exciting. That's very exciting. I'm happy to be involved and to share my experience